When we speak about the visual field, it is mandatory to say a few words about the different types of defects that happens in glaucoma. Glaucomatous visual field changes is classified into specific changes and non-specific changes. Specific changes that's peculiar to glaucoma, and non-specific changes can happen in glaucoma and in other diseases. So the specific changes can be classified or subdivided into an early changes, late changes, and advanced changes. Early changes that's in early glaucoma can be paracentral scatomas or cedar scatomas or nasal stip scatoma. Paracentral scatoma within 10 to 20 degrees of the visual field, and cedar scatoma, that scatoma fuses with the blind spot. And the nasal stip is a peripheral scatoma that encroaching over the central field from the nasal side. The late changes include arcuate scatomas in the germ area or germ scatoma, double arcuate scatoma when the two scatomas in the upper hemifield and lower hemifields are fused together, and when they fuse together, they may be left with a central nasal stip that's called Roney stip. So Roney stip is a scatoma in the central field due to fusion of the upper arcuate and lower arcuate scatomas. Then finally, the advanced stages of glaucoma, you will find a tubular visual field, or you find a temporal island of vision, and the total blindness, total blind. So this is the different types of visual field defect that occurs in glaucoma. The other changes that occurs in the visual field due to glaucoma is the non-specific changes. And by non-specific, we mean that it can occur in glaucoma and can occur in other diseases. The common and the popular one is the constriction of the isopter, and this term is usually seen in kinetic perimetry, in which there is a focal constriction of the isopter of the visual field. The other thing is pairing of the blind spot, which means exclusion of the blind spot from the central vision. And also this is usually seen in kinetic perimetry, not seen in static perimetry. The other changes is enlargement of the blind spot, maybe due to atrophy of the peripapillary atrophy associated with the glaucoma. There will be an enlargement of the blind spot. And however, all these changes are not specific for glaucoma, but this is also seen in glaucoma. Among the new advances in glaucoma is in the glaucoma pathogenesis is a newly emerging theory that explains the exact pathogenesis of glaucoma. As you know, in the previous traditional teaching to our fourth-year students and in the postgraduate students, that there are two theories explain what happens to the optic disc in glaucoma, either the mechanical theory due to elevation of the intraocular pressure, or the vascular theory due to ischemia to the optic nerve. However, these previous two theories have failed to some extent to explain some of the phenomena that happens to the optic disc and to the patients if we depend solely on these theories. A newly emerging theory is the what's called the optic disc axotomy theory, invented by the Dr. Sayyid Hassanein and his co-assistant Aziz Hassanein in 2023 and published in the EC Ophthalmology Journal as a review article. It highlights a new concept of pathogenesis of glaucoma, and also it opened the door for a new definition of glaucoma as instead of being an optic neuropathy and to be as optic disc axotomy. So we will come and study about this new theory and see how can this theory explain to a large extent the different changes that happens in glaucomatous patients. Before I speak in details about the axotomy theory behind the glaucoma, I would like to emphasize or highlight some of the important fundamental contradiction challenges. One of these challenges is that the cupping theory, or the cupping induced by the elevation of the intraocular pressure, fail to explain the systematic and the orderly manner that happens in the visual field. Because when you look to this slide, this is the optic nerve, and this is the fibers from the retina. Now you can see that the fibers from the far peripheral part of the retina, they are occupying the outermost part, and they are facing the sclera. And when they turn 90 degrees to enter to the optic nerve, they occupy the peripheral part of the optic nerve. However, the fibers from the central part of the retina and the papillomacular bundles, they occupy the innermost part of the nerve fibers. They are facing the vitreous, and when they turn to 90 degrees toward the optic nerve, they occupy the central part of the optic nerve. So if there is a cupping here in this area, by logic, this is like a crater, enlarging crater. So this cupping should initially damage the central fibers that's representing the central vision. And this is not happens. Usually the central vision is the last to be affected, and the first to be affected is the peripheral vision. So this cupping theory failed to explain the changes that happens in the visual field. Normally we see in the visual field in glaucoma the changes in the peripheral vision first, then last thing to be affected the central vision. That's why here this theory tried to explain why this systematic and orderly manner the changes in the visual field. The second puzzle question that is important: how does this elevation in the intraocular pressure directly affect the nerve fibers layer? They claim that there is a two-stage effect of the intraocular pressure that's not directly affecting the nerve fibers, but it is affecting the nerve fibers indirectly. So this revised the theory that's the exotomy theory. It challenges the traditional understanding of glaucoma and provide a new perspective on the pathogenesis of the sight-threatening condition of glaucoma, and it will open the door for further investigation regarding the exact pathogenesis and the etiology and also the definition of glaucoma. The oxotomy theory, here I will explain in a brief, according to the people who invented this theory, that it is made up of two stages. The first stage is the biological stage, in which elevation of the intraocular pressure, this will exert or causes ischemia for the border tissues adjacent to the optic disc, and with this will initiate a degenerative changes in this border tissues of Elshing, as well as changes in the lamina cribrosa. Now at this stage only a degenerative stage, and still there is no any mechanical stage. Now when this stage progress to the mechanical stage that coincides with the elevation of the intraocular pressure and pre-existing degeneration at the border tissues of Elshing's. This will lead to sinking and bowing of the lamina cribrosa. Now this sinking and bowing of the lamina cribrosa is the prime factor that is responsible for severance and damage to the nerve fibers adjacent to the sclera. And this process will be in orderly manner from peripheral fibers representing the peripheral retina up to the central fibers representing the central retina, and this explains the changes that happens in the visual field. So as I explained, you can see the fibers from the peripheral part of the retina, they occupy the peripheral part of the most superficial part of the fibers of the nerve fiber layer. They are facing the sclera, and when they bow at the optic nerve, they take a 90-degree course and they occupy the outer part of the optic nerve. Similarly, the fibers from the central part, or representing the central part of the retina and the papillomacular bundles, they occupy the innermost part of the nerve fiber layer facing the vitreous, and when they take a curve of degree toward the optic nerve, it will occupy the central part of the optic nerve. Now, the changes this happens, that's the severance of the fibers of the optic nerve is associated with damage to the vasculature accompanying the fibers, and this explains the splinter hemorrhages that you see in the disc in the peripapillary area and in the disc area. And also another finding is the intra-disc hemorrhages or cup hemorrhages here. Now this hemorrhage is explained by the damage in the lamina cribrosa, to the extent that even disinsertion of the lamina cribrosa, this will lead to, even in advanced cases, to the disinsertion of the lamina cribrosa and the appearance of this disc hemorrhages, like as you can see in this slide. So axotomy theory could explain to a large extent the various changes that happens in the visual field from peripheral to the central visual field, also the accompanying signs of glaucoma like the splinter hemorrhages. And this axotomy theory opens the door for a large area of investigation regarding the etiology and the pathogenesis, and could shift the definition of glaucoma from being just an optic neuropathy to an optic disc axotomy. The main advantage of the axotomy theory that it succeeds to explain the correlation of the glaucomatous visual field defect along with the and its relation with the nerve fibers. Now, among the myriad of glaucoma theory that try to explain the relation of the glaucomatous damage and the visual field changes, none of the prevailing theories encompass to explain the systematic and orderly manner of changes in the visual field. By orderly manner, I mean you can see the visual field start as changes in the paracentral area, and then these paracentral scotomas, they coalesce together along with the blind spot, they form the sedal scotoma, and then enlarge form the germ scotoma or arcuate scotoma. Then double arcuate scotomas will form the ring scotoma, and also at the peripheral part you can see that there is generalized constriction also in the peripheral part, and when both of them they fuse together they form a tubular visual field, and then the patient will lose his vision. This regular orderly manner of visual field changes can be explained by this theory based on the anatomical distribution of the nerve fibers, and it says that from day one all the nerve fibers are affected. The reason why these arcuate fibers are more prone because they are less in number as compared to the central papillomacular bundles. The papillomacular bundles are much abundant, and the changes appears in the peripheral part. That's why the arcuate fibers, which is less in number, they are affected early. However, the papillomacular bundle is the last to be affected because they are plenty and there is abundance of the papillomacular bundles. Now, among the things that is good in this theory, that it explains the changes that occurs in the normal tension glaucoma and in the chronic simple glaucoma. So it says that the border tissues around the optic nerve is supplied from the ciliary circulation, which is an end arteries, and is not supplied from the central retinal artery. And the pressure, that circulation is low pressure circulation, is around 25 millimercury. And you know that the intraocular pressure is 21 millimercury. So there is a pressure gradient between the pressure within the circulation within the border tissues and the eye, which is 21 millimercury. So the blood supply will go normally, and the changes that happens in the border tissues is due to elevation of the intraocular pressure. When the intraocular pressure, for example, elevated to 26 or 27 millimercury, this will result in decrease in the blood supply and the perfusion pressure, and accordingly there will be degeneration and changes in the border tissues, and in turn into the lamina tuberosa. As seen here in this diagram, this is the normal ciliary pressure, which is around 25 millimercury, and this is the normal intraocular pressure, it's around 21. Now, when there is elevation of the intraocular pressure beyond the 25 level, so this is the problem that will happen in glaucoma. Contrary to that is the low tension glaucoma. Now, in low tension glaucoma, the tension is normal, which is, for example, 16 or 17, but the ciliary pressure, because of any disease leading to hypoperfusion, leading to decrease in the pressure in the ciliary circulation, and in turn decrease the pressure within the border tissues. So even a pressure of 20 millimercury is regarded high for that patient, and in turn will lead to degeneration to the border tissue and start the process of glaucomatous damage. So axotomy theory could explain both the changes in the high tension and low tension glaucoma. As far as the theories behind the pathogenesis and the etiology of glaucoma, we have discussed this in the lecture of the interpretation of OCT in glaucoma, that there are different theories. The mechanical theory, that's the pressure dependent, and the vascular theory, that's the flow dependent, and also there is genetic theory. In the subdivision of the vascular theory is what's called the watershed theory. Now, a watershed theory means that As you know, the eye has a dual blood supply, and in the watershed theory, it says that the superior and inferior pole of the optic disc are watershed area. They have a dual blood supply, and the terminal ends of these blood vessels are end arteries. And whenever there is ischemia or hypoperfusion, this area will be compromised. That's the superior and inferior pole. So that's why they try to correlate the changes in the visual field that happens in the glaucoma, partly due to the changes in the optic disc. However, part of the changes in the visual field is related to the watershed zones, which is present in other parts of the retina, in the equator and in the terminal buds at the ora serrata. This is a big theory and beyond the scope of this lecture. However, for you as a postgraduate student, you should know a little bit about the watershed theory and what are the watershed zones of the eye. There are different watershed zones in the equator that divides the eye into anterior and posterior parts, and also in the near to the ora serrata, and also near the optic disc, that's the superior and inferior pole. So this is subdivision of the vascular theory, supporting the principle of watershed zone as an insult or incriminating factor in the etiology and pathogenesis of the visual field changes in glaucoma. This slide summarizes the changes in the visual field in the glaucoma. This is the blind spot. This is the blind spot, and this is a small scotoma attached to the blind spot, so named as sedal scotoma. And this is small paracentral scotoma, and this is the germs area and germ scotoma. And this is a centrocecal scotoma. From the point of fixation to the blind spots, it's called centrocecal scotoma. If the scotoma in this area, this is the central scotoma. If there is another scotoma here, this will be called inferior arcuate scotoma. If it fuses with the upper arcuate scotoma, it will form the ring scotoma. And this is the nasal step. This is a peripheral scotoma that encroach over the central field. And it differs from the Ronay nasal step that occurs when there is a fusion of the upper and inferior arcuate scotomas. Similarly, this is the visual field. Exactly the same finding. This is tubular field with temporal island vision, and this is total blindness. Now there is a new concept of selective functional testing. As you know, in the standard automated perimetry, the assessment of the retinal function is done globally without specific types of ganglion cells. As you know, there are different types of ganglion cells, the parvocellular cells, the magnocellular cells, and the conicellular cells. In the standard static automated perimetry, we assess the retinal function globally without selective targeting a particular type of ganglion cells. However, the concept of selective functional testing is targeting a particular type of ganglion cells that is more susceptible to the glaucomatous damage. We will see this in the coming slides, because to have a changes in the visual field, nearly 40% of the ganglion cells should be damaged before you can note changes in the visual field in the standard automated perimetry. And since our target for early detection of glaucoma, so we have to pick up the glaucomatous changes as early as possible, and hence a selective targeting of particular type of ganglion cells may open the door for a new era of investigation that selectively targeting particular type of cells and leading for early detection. We will study this one by one, especially the short automated wavelength perimetry and the frequency doubling perimetry. Of the ganglion cells, that there are three different types: the magnocellular cells, parvocellular cells, and the conicellular cells. That's the different types of the retinal ganglion cells. The magnocellular cells is this one that it is large in size and mainly meant for motion sensitivity or motion detection. Also, the conicellular cells are large cells, but this is insensitive to the motions. And the small cells is the parvocellular cells, which is meant for color detection. So based on the function of these ganglion cells, A new techniques has been developed for selective testing of these cells. For example, the short wavelength automated perimetry. Now, as I said, that the conventional perimetry is not selective because it tests a variety of the retinal ganglion cells in the whole retina. However, we will see in the short automated wavelength automated perimetry, it's selectively targeting special type of ganglion cells. So this is the what's called white on white perimetry. The white stimulus will stimulate all cells together. So as you can see here, there is a blue stimulus of large size, usually size 5. This will targeting the blue cones, and the other cones will be bleached by this yellow background. And this is the background yellow, and the stimulus will be in blue colors. And this will gives the principle. This is the principles of the short wavelength automated perimetry. So the short wavelength automated perimetry is more sensitive test than the standard white on white perimetry, as it can detect the retinal changes in the glaucoma 40% much before the changes occur in the standard automated perimetry, maybe up to 5 years before that the changes occurs. And it uses a stimulus size of 5. Now, nothing is perfect in this technology. The disadvantages of the short automated wavelength perimetry that it needs a learning curve and it takes a long time duration as compared to new strategies of the standard automated perimetry. And also it is affected by medial opacities. So if there is cataract, it will be affected. And it has greater variability associated with the estimation of the threshold, and it has increased the examination time. This is the disadvantages of the automated perimetry as compared to the, I mean, this is the disadvantages of the short blue and white automated perimetry as compared on white perimetry. Another example of the selective targeting of the ganglion cells in the retina, as we spoken before about the short automated wavelength perimetry that is selectively targeting the conicellular cells. Now, there's another technology called the frequency doubling perimetry, in which special stimulus, which is sinusoidal grating of low spatial resolution of around 5 degrees and with high temporal resolution of around 18 hertz is exposed to the patient. And this type of stimulus will induces a illusion of frequency doubling. This is the principle, and it mimic an motion stimulus to the retina, and hence it stimulate the magnocellular cells that is responsible for the motion. So these magnocellular cells are a small population of cells in the retina, around 3 to 5% of the total ganglion cell that's present in the retina, but it is selectively affected in glaucoma. And accordingly, the frequency doubling perimetry is selectively targeting these cells, and it can detect early glaucoma changes before the standard automated perimetry. So the target or the stimulus is bars of dark and bright bands with a low spatial resolution of around 5 degrees and high temporal frequency of around 18 hertz. This will create an optical illusion of frequency doubling, as if the patient is seeing more bars than what he's seeing. And this will stimulate or mimic emotion to the patient and stimulate the magnocellular cells. Of the frequency doubling. So this is the different varieties of ganglion cells in the retina. Now, when we expose the patient to this type of stimulus, that's sinusoidal grating with low spatial frequency and high temporal frequency, it's selectively targeting the magnocellular cells, and it induces a motion stimulus to the patients, and we can
detect early changes in glaucoma based on this test. It is called frequency doubling. So frequency doubling is useful in glaucoma, and it is selectively targeting the M cells, that's the magnocellular cells, which constitute 3 to 5% of the total cells in the retina. And the target is around 5 degrees square of alternate dark and light bands. And it goes a high frequency of temporal frequency of around 18 hertz, and it based on the principle of optical illusion of frequency doubling. Looks like, and it is useful and very good in early detection of glaucoma. And even the printout mimic the standard automated perimetry with a matrix of 24-2 frequency doubling, and the result is similar to the CETA standard in the static automated or the standard automated perimetry, and we can compare the result with that type of field.
Okay, we come to the last session, which is the guided progression analysis. This to remind you that we have finished the different test strategies that is used in perimetry, and the different test patterns in the form of 30-1, 30-2, 24-2, 24-2C, and 10-2. Also, we finish all the items of the interpretation of the perimetry map, the single field analysis. And now we come to the last session, which is the guided progression analysis, either in Humphrey visual field or in Octopus. And Humphrey, like the guided progression analysis using event analysis and trend analysis, and the cluster analysis as done in Humphrey, done in Octopus perimetry. That's the polar analysis and the cluster analysis. This is very important session, and this is the last session, and we will go step by step to understand this terminology. The last session of interpretation of perimetry is the guided progression analysis, and this is very important part that after you finish the diagnosis of glaucoma and the interpretation of the perimetry printout, the difficult questions is your patient is stable or he's in a state of progression, and the machine do all the necessary statistical analysis that shows you the status of the patient, whether he is stable or progression, based on the guided progression analysis, which is available in Zeiss machine. And here I should emphasize that for establishing a glaucoma progression, you should rely on both the structural changes in the retina as well as the functional changes in the perimetry. That you should not depend only in one of them to establish a glaucoma progression. You should depend on the clinical examination of your patient as well as the structural changes using the OCT, and finally the changes, the functional changes using the perimetry. As you know that the structural changes precedes the functional changes. So to have a good progression analysis and assessment of your patients, you should, based on the stage of glaucoma of your patient, whether he's in early stage or moderate stage or advanced stage, you should use these two utilities, that's the structural as well as the functional changes, to be in a solid ground to say that whether your patient is stable or not. If your patient is not stable, so at that time you need to do interventions, either in the form of surgical interventions or medical intervention. So we will go slowly to understand the guided progression analysis.
You can see here the different types of analysis that is done in glaucoma with different machines, either Octopus or Humphrey. There are different types of analysis, and each one has specific advantage and disadvantage. The functional assessment of the glaucoma and the event-based analysis and trend-based analysis, point-wise linear regression, global trend analysis, cluster analysis, and Bison analysis. We will choose some of these and speak a few words about them. Those who are interested, they can read more about this, and I will leave a reference for this.
The glaucoma progression Glaucoma progression, as simple as that, it means that we determine the progressive death of retinal ganglion cells, and hence it will affect the retinal function. And this the glaucoma progression, clinically to detect this progression is not simple, and very challenging aspect. And for the clinician, he should not be satisfied just by the diagnosis of glaucoma and giving the treatment to the patient without asking this question: is your patient is stable or not? If your patient is stable, that's it. If your patient is not stable, so you have to interfere either surgically or medically to make him stable, to preserve his visions. And in the next slides, we'll go and see the different types of glaucoma progressions and the different methods, like the glaucoma changes probability and the guided progression analysis by Humphrey, either an event analysis or trend analysis using the VFI or the mean deviations. A glaucoma progression can be classified as being a structural analysis or structural progression, or functional progression, or clinical progression. Now, all of them should be taken in consideration to handle the patient's data and to come up with a final conclusion that the structural changes or assessment should not be done away from the functional changes. By functional changes, I mean the perimetry, and the structural changes, I mean the changes in the OCT, in the nerve fiber layer, and the optic disc. And the clinical changes, for example, the optic disc hemorrhages, the uncontrolled intraocular pressure, all these are factors and parameters that signifies the progression of glaucoma in that patient, and should all these be taken into consideration to come up with a final conclusion about the status of the patients. So to establish and to have a glaucoma progression analysis by the machine, you need to have at least two basic reliable visual field studies with reliable indices with minimum false positive and false negative, and another successive follow-up visits of 1 or 2 and more. This will be helpful to establish either an event analysis or a trend analysis. So progression is evident when you find increase in the negativity of the mean deviation. The mean deviation could be a positive value or a negative value. A negative value indicates further depression of the sensitivity. Positive mean deviation can be normal, or it can be due to a false positive result. And drop in the negativity and the mean deviation, along with the decrease in the visual field index, this indicates that there is progression. This progression can be in the form of enlargement of pre-existing scotoma, or deepening of pre-existing scotoma, or occurrence of a new defect. Now, deepening of pre-existing scotoma may not be easily identified, especially in the total deviation probability plot or pattern deviation probability plot. So this can be evident by looking to the grayscale. You can find that there is increase in the deepening of a pre-existing scotoma. Keeping in your mind that the main deviation represents the whole hill of vision, and when there is increase in the negativity, it indicates a uniform depression of the sensitivity. And the mean deviation is not very sensitive, as it can be affected by general depression due to cataract. So the use of VFI along with the mean deviation will be useful, because VFI will not be affected by the presence of cataract. So as I said, that we use the mean deviation, that there will be an increase in the negativity to establish a progression, and decrease in the visual field index and the follow-up visual fields, if these two are associated with the changes in the pattern standard deviation. Now, the pattern standard deviation signifies a localized defect in the visual field or in the hill of vision, and it indicates a localized depression. So if these three are present, this indicates there is a glaucomatous changes or a progression in the form of localized depression. However, if you find the pattern standard deviation is not changes, this doesn't rule out glaucomatous progression in the presence of increase in the negativity of the mean deviation and decrease in the visual field index, but along with a uniform depression. This will show a uniform depression of the hill of vision. But if the changes are stable in the mean deviation and the visual field index, and there, of course, there will be no changes to the better standard deviation. At that time, we can safely say that there is no progression for our patient. I repeat again, all of these changes should be studied carefully in a reliable visual field. You have to have a reliable visual field. Don't depend on unreliable visual fields. Of course, nothing is perfect. There is some limitations for the visual field index. That is, the visual field index is useful in moderate to advanced glaucoma. However, it is less sensitive in early glaucoma. This is number one. Number two, the data extracted from the visual field, that's we extract the visual field index from the pattern deviation probability plot. Now, if the mean deviation of the study is dropped below minus 20 decibel, at that time the pattern deviation probability plot will not be created, and hence the visual field index will not be reliable at that time, and it will be extracted from the total deviation or from the mean deviation. So it is very important to make sure that when you interpret the study that the mean deviation is not dropped below minus 20 decibel, and that your visual field index is extracted from the better deviation, not from other calculations. Another point, that the visual field index take more weight for the central points as compared to the peripheral points. So it is more representative of the residual central vision of the patient than the periphery. The glaucoma change probability analysis made up of three sectors. The first zone is the baseline visual fields. At least two baseline visual fields you should have to do this analysis. And the second sector is the middle one, which is the VFI. That's the trend analysis and the VFI graph. And the third zone is the event analysis. And generally, you need at least 5 visual fields to perform this progression analysis, 2 as a baseline, and another successive 3 visual fields to do the trend analysis and the event analysis. When we speak about the glaucoma progression or glaucoma progression analysis that is present in the Humphrey visual field, glaucoma progression poses a very substantial challenging problem to doctors and clinicians, as the slowly progressive nature of the disease that make it difficult to identify or track the changes over a period of time. This is one factor. And another factor is the age-related or the annual decay or the age-related changes in the sensitivity of the retina, which is physiological changes related to the age, and the presence of a coexisting pathologies like cataract or age-related macular degeneration make these confounding variables very challenging to determine whether the changes that you have noticed in the visual field is really due to a real progression, or it is due to the normal changes with age, or due to a test fluctuation. So there is no gold standard definition for the glaucoma progression, either structurally or functionally. And based on this, a special softwares and statistical analysis was incorporated in the Humphrey visual field to help the clinicians to determine in a solid ground whether there is a real progression or this is an unreal progression. This is one aspect. Another important aspect, the functional progression cannot be isolated from the structural progression. That's to say that we have to look to the structural changes and the structural progression by means of the OCT changes, along with the functional progression, along with the perimetry changes, to form a final conclusion about the status of the patients. So in the event analysis, we analyze the retinal sensitivity point by point, and we establish a baseline average
for the first two visits of the patients based on the pattern deviation probability plot. So the first two consecutive visits is regarded as an average, and we draw a line, and this is done for each and every point in the retina. And after a successive visits, we determine the average sensitivity for each visit, and if the one of the visits they cross this average line, this is regarded as abnormal and is highlighted in an empty triangle if it is for the first time. And if it is crossed for the second time, it is highlighted as a half triangle. And if it is crossed for the third time, it is highlighted as a black triangle. And this is plotted in the probability change map. So this is how we can read the event-based analysis based on this. So when this is full black, this is a real indication that there is a real progression. However, this one need another visits to confirm that it is a real progression. This is how the event analysis works.
The event analysis, this is where we compare the successive visual fields point by point. So it gives very good idea about the focal defects, and it is shorter in time as compared to the trend analysis. Trend analysis needs very long time and needs multiple visual fields to establish a trend analysis. However, event analysis requires less time and less visual fields after the two basic visual fields to detect if there is an event analysis or changes in the focal points in the visual fields. And it is read as following. If you find the three spots with this triangle with half-filled triangle, it indicates a possible progression like this one. If you have 3 points with this half-filled triangle, indicate a possible progression in your patients. However, if you find a dark triangle, 3 spots with dark triangle indicate a likely progression. So event analysis represent a focal defect, and it needs short time and less number of visual fields to establish this analysis. As far as the trend analysis requires multiple visual fields, and it needs long time of duration to establish the trend analysis, and the changes in the retina of the glaucoma patient changes from one patient to one patient, and also within the same patient, different location within the retina, they have different progression. So the trend analysis is based mainly on the mean deviation and visual field index. However, the mean deviation is affected by the presence of generalized depression for other reasons like cataract, as we said before. However, the visual field index is useful predictor for the future of the patient. If we could have two basic visual field baselines and a successive 3 visual fields over a period of time, we can do linear regression and predict what could be the prognosis of the patient over the next 5 years. However, as I said, that sometimes the different locations of the retina, they have different trend analysis. The trend analysis is very useful tool to predict the velocity of progression of the disease in the patients. And as I said before, it is dependent on 2 variables, the visual field index and also in the mean deviation sometimes, because the visual field index mainly concentrates in the central area of the vision and is not affected by the presence of cataract. And the data for the visual field index is extracted from the pattern standard deviation. So it is not affected by cataract. However, if the mean deviation of the patient dropped markedly below 20 decibel, in this situation, as I said before, the pattern standard deviation will not be formed, and at that time the visual field index will extract its informations from the total deviation, and at that time it becomes less reliable. So that the visual field index correlates with the velocity of the speed of the progression of the disease based on linear regression. As you can see here, there is a serial or gradual drop in the sensitivity of the retina of this patient. So we, by linear regression, we can predict over the next 5 years what will be the prognosis for the patient for this eye. The normal decay or the decrease in the sensitivity per year should not exceed more than 3% per year. And if it is more than 3%, it will be regarded as abnormal, which is equivalent to about 1 to 1.5 decibel in each point of the retina, especially the central area per year. So trend analysis is very useful and it needs long time to establish this trend analysis. However, it is very useful to the clinician to predict the prognosis of the patient.
This is example of the trend analysis for the right and the left eye. As I said, that the trend analysis evaluate the progression of the disease over a long period of time. So for short-term fluctuation of the retinal sensitivity cannot be determined by trend analysis, but it is determined by event analysis. However, for studying the progression over a long period of time, the trend analysis is more useful. Now, in this case, this is the trend analysis for the right eye and for the left eye. As you can see that the left eye, this is the progression over many years, and it is still above the normal threshold. And however, for the left eye, there is decline in the trend analysis, and this is the expectation over the next years. As you can see here, there is extrapolation for the sensitivity over the next few years. So this patient, we need to take new actions, either modify the treatment or you might convert him to surgical intervention, because as you can see, you can predict that the progression of this patient for the left eye is very high. And the visual impairment is more than minus 14 decibel, and this is the advanced legal blindness.
So in summary, the main difference between event analysis and trend analysis, that event analysis focus on a significant magnitude and the difference between 2 points or 2 values in the successive visual fields. So it utilizes point per point comparison over a successive visual fields, and hence it requires fewer visual field tests and less time to produce this result. However, the trend analysis will require long time because it determines the progression of the speed or the speed of the progression of the disease. It requires longer time to find this relation. However, the trend analysis have high diagnostic sensitivity than the event analysis as far as medium and long term.
Among the unique features of the octopus perimetry is the defective curve or cumulative defective curve, or the PP curve. This curve is a simple curve and simple to read, and it's basically based on the comparison chart in the octopus, or in Humphrey terminology, the total deviation chart. So all the values are arranged regardless its location. The smaller values in the left and the larger values in the right side, and this is the appearance of the normative data, as you can see here, and the patient's data are plotted, and we see the relation between the normative data and the patient's data. So we can see different scenarios as in this slide. This is the normally that the patient's data coincides with the normative data, and it might be a generalized downward shift of the curve, which indicate generalized depression in the retinal sensitivity. Or sometimes the normative data is okay, then sudden abrupt drop or shift in the right side of the slope of the curve, or a combination of both, of generalized downward shift along with the defect, so indicate a local and generalized depression. So it is a nice and simple curve that immediately highlights what's wrong with this patient, and it makes you think what could be the reason for this, either generalized depression or a combination of low focal or generalized depression, or just focal depression. Another useful thing from this curve is also it highlights the trigger happy patients. If you find abnormally high sensitivity of the curve, as you can see here, beyond the normative data, so this might indicate a trigger happy patient. One peculiar analysis to octopus that is perform a special analysis that's useful in the early detection of glaucoma is called the cluster analysis. And I think this analysis is similar to that, or in comparison to the glaucoma hemifield test that is peculiar to the Humphrey visual field. Now, in this cluster analysis, the reduced retinal sensitivity is determined in all the retina, and the retina is clustered in different sectors, superimposed in the distribution of the retinal nerve fibers, RNFL. So it is based on the principle that glaucoma will cause sectorial damage to the retinal nerve fibers, in particular clusters. So when they superimpose for example, the G matrix of the octopus field with the RNFL map, and they divide the retina into 10 clusters that is corresponding to the distribution of the nerve fibers that is more vulnerable to the glaucoma. This is some sort of structural functional correlation. That's the special structure or location in the retina is corresponding to loss of function in the visual field. And the mean of this sensitivity loss is determined and is plotted in each one of these sectors. For example, this is the paracentral, superior paracentral cluster, plotted in red color, and this is the values of reducing sensitivity. And the mean value of this reducing sensitivity for each cluster is measured and represented on each cluster. Then, of course, a statistical analysis will be applied, and a probability testing will be there, and the mean deviation will be measured, and we extract the p-value for each cluster, and accordingly we can determine the abnormal cluster that carries a high suspicion of glaucomatous damage. This is in brief, the cluster analysis that is seen in octopus. Here, I would like to say that this cluster analysis can be performed for different perimetry matrix peculiar to the octopus. For example, the G map, and this is the 30 or 30-2 or 32-2 and 24-2 for the octopus. And this areas is divided to 10 clusters, and the same thing that I mentioned before is applied, and accordingly we can determine the damaged cluster that carries high probability of being related to the glaucomatous damage. And as I said, this is something similar to the glaucoma hemifield that is performed in Humphrey perimetry.
Another very useful analysis done by the octopus machine is the polar analysis, and this is also an important analysis useful in the early detection of glaucoma and determine the early glaucomatous changes. In this polar analysis, the changes in the reduced sensitivity in the comparison chart is tracked back through the nerve fibers to the optic disc, and determine the angulation and the locations of the optic disc corresponding to the damage in the nerve fiber of the comparison chart. And this is represented in radial bars along the optic disc, with this gray zone is the normal range, and the bars beyond the gray zone is the abnormal bars. So as you can see here, there are very long bars here in the inferotemporal area. This indicates that the inferotemporal part of this optic disc is damaged. So the polar analysis displays the sensitivity loss from the comparison chart as projected into the optic disc. So this is very important that it establish a structural functional change relationship. The functional changes in the visual field is tracked back and reflected to the optic nerve, and according to the Garway-Heath postulation for the distribution of the nerves on the optic disc, we can transpose or invert the image. The software of the machine will invert the image horizontally, as you can see here, to guide you where is the location and where you will examine the optic nerve. So after doing the visual field, you can determine exactly where is the area of damage in the optic nerve. For example, in this patient, it is in the inferotemporal area, which is more in favor of glaucoma. So this is very useful utility. That's the polar analysis.
is one unique analysis also done by the Octopus machine. So by the end of this lecture, our aim from this lecture to highlight the importance of reading the visual field map, and our aim is beyond the interpretation of the perimetry map is for the early detection of glaucoma by using what's available technologies in the form of OCT or short wavelength automated perimetry or the frequency doubling perimetry. So our aim is for detection of glaucoma in the pre-perimetric stage, that's before the changes occurs in the perimetry. Because as we spoken before about the functional structural relationship that at least 40 to 50% of the retinal ganglion cells will be damaged before the initial visual field changes, even with early detection of the visual field. So the functional changes in the retinal sensitivity appears late as compared to the structural changes that's detected by OCT. So to establish a good program for early detection and then good management and prevention of glaucoma is we should work in the early detection of a pre-perimetric glaucoma to counteract this second most leading cause of blindness, that is glaucoma. So the message that I would like to send to the all junior doctors or specialized postgraduate doctors who are interested in glaucoma is our aim not just only for picking up the patient who's already glaucomatous patient, but we should do our best to pick them early stage in the pre-perimetric stage and even before the pre-perimetric stage.
So by this level of this lecture, we reached to the end of this session of perimetry interpretation, and I hope that you have benefited and enjoyed this lecture, including the basis of perimetry as well as the different strategies, also understanding the establishment of progression analysis using the perimetry and the different types of progression analysis. And I suggest all postgraduate students who are more interested in the perimetry to read this book, which is the Effective Perimetry. It contains all the necessary informations and data that you need for you as a practitioner. And also the excellent perimetry book by Zeiss, which will be available by next March. So I hope that you will be all right, and I hope that I will meet with you in another session in the coming lectures in the series of Ophthalmology Made Easy. For that time, I hope that you will be all right, and looking soon to meet you and wishing for you good luck. بهذا أعزائي الطلبة نكون وصلنا إلى نهاية المحاضرة الخاصة بالبريمتري. نتمنى أن تكونوا قد استفدتوا بهذه المحاضرة، ولنا لقاء يتجدد في المحاضرة القادمة بعنوان الفيكو داينامكس. كل الروابط موجودة الخاصة بقناة على اليوتيوب أو الفيسبوك للتواصل لأي استفسارات. وإلى لقاء قادم، استودعكم الله والسلام عليكم ورحمة الله وبركاته.